Let me share my screen.
So Shemra Rizzo is a senior data scientist at GeneTech's personalized healthcare group. And in this talk, Shemra's going to talk about making sense of electronic health records, EHR data, for COVID-19 early in the pandemic. You recently moved to North Carolina, is that right?
Oh, yes. Sorry, I was getting lost with, I feel like I was not really controlling the screen. Uh-oh. I don't know how to go back. Oh, here we go. Sorry. Redo. Yes,
so
I recently moved to North Carolina.
Yeah, I hope you're all set up there.
Yeah. It's definitely different weather than in California. I'm having a hard time getting used to not having the sunshine in the morning.
Yeah. Thanks very much for your presentation, and I'll hand it over to you.
Okay, thanks. All right, let me. I'm not used to using Zoom. Oh, here we go. All right. So the title of my talk today is Real World Data in a Pandemic, Making Sense of EHR Data for COVID-19 with Reliability and Reproducibility Considerations. I want to start, okay. I want to start my talk by acknowledging my team members and colleagues whose work I will be covering today. And I want to give a special shout out to Kelly Salukowski, Devi Kachala, and Devin Incharti. Okay, so as you all know, COVID-19 was declared a pandemic early last year. And for researchers like me that research real world data, this was a very unique situation. So let me explain to you how abnormal this was by talking to you about how it typically goes. So for a typical infection disease like influenza, we have lots of real world data, lots of historical data that we are able to analyze in observational studies to derive insights to inform randomized controlled trials. But for COVID-19, we were around the world starting clinical trials while simultaneously collecting the real world data. So we were in this very unusual situation where we needed to derive the real world data insights pretty quickly. So today I'm going to talk to you about the first two COVID-19 studies that my team and I worked on. The first one is very foundational. It's a descriptive epidemiology study of hospitalized COVID-19 patients in the US using their electronic health records. And before I go a little bit further, I just wanted to clarify the terminology real world data and what it really means. It sounds a little bit technical. And what it is, it refers to patient health data that is collected routinely, like in the hospital, like electronic health records and medical claims. And that we need to distinguish that from data that comes from a control environment, like a clinical trial. So the most common source is EHR data, and that's what I will be talking about today. So in this epidemiology study, what we wanted to report were summary statistics of key outcomes. So the things that we were interested to know were, what are the demographics and comorbidities of the patients that end up in the hospital? What are their vitals and laboratory metrics on admission? What medications did they receive during their hospitalization? And what were the clinical outcomes, such as ventilation rates, ICU stays, mortality rates? The second study that I will be covering today is this rigorous prognostic model for mortality that we developed for these patients, the ones that were hospitalized with COVID-19. And what we really wanted to do is to identify and quantify the risk factors for mortality. So we were in this challenging situation where, well, the first thing we did was to license EHR data from the US at various hospitals across the nation. And it was challenging because working with EHR is a massive amount of data. It requires a lot of cleaning, very time consuming. We were dealing with a new disease, so a lot of things like definitions were not static, were constantly evolving. And we also had this additional challenge that internally, we had a lot of research teams with their own research questions that were depending on us to make these foundational first steps and making sense of the data. So with this background that we were operating with, we had 4 very important considerations. So first one was the rapid delivery of results. The second one was making sure that the results were reliable. And then the third and fourth one was to make sure that our studies were replicable and reproducible. So first, I want to start by giving you a taste of what it is like working with EHR data for COVID-19. The very first challenge that we had was the case definition itself. Who has COVID-19? It's not as easy, like there definitely wasn't a column with ones and zeros telling you who got COVID and who didn't. So the way it typically goes, if you want to find, for example, a patient with influenza in the medical records or with asthma, you have these diagnosis codes that are known as ICD-9 and 10 codes to look for those patients. But COVID-19 being a new disease, there were no COVID-19 codes. So what we learned was that medical coders in the hospitals were using this code B9729 that historically had not been used very much. It's a coronavirus code, but it hadn't been used very much. So it served perfectly as an interim code while the official ones were underway. So in April, the official codes U071 and U072 kicked in and replaced mostly, but not completely, the usage of the B9729 code. So when we're looking for patients, we needed to account for this variability and the timing so that truly assess the real diagnosis date of a patient. That was not the only challenge, because there was a second pathway to identify a COVID-19 patient, and that is via a positive nasal swab test. You've probably seen lots of pictures of people getting poked in their nose. So those are definitely in the data. We wanted the positive results, but it was challenging because these tests didn't exist before COVID-19, right? So they were being developed while the pandemic was going, and almost every few weeks there would be new labs that were developed by new companies. So when we're looking from the data perspective, we're looking at the strings that describe the test, and we didn't have a fixed list. So every time we got new data, we needed to update that list to include the newly developed swab test. And our script needed to account for several challenges. First, we needed to make sure that we weren't picking up the coronavirus test for the coronaviruses that give us colds. Those were of no interest. Also, for coronavirus that give you COVID-19, we needed to not pick up the antibody test. We really were only interested in the PCR diagnostic test. And so the code was looking through was string-based search, and you can probably have an idea of how challenging that was and time-consuming to develop. The second challenge was the hospitalization definition. Who was hospitalized and for how long? So in this example, we have a patient that was hospitalized from April 1st to April 30. But that is not what we see in the data. What we see in the data is a collection of records from different settings with different lengths. So for example, first, an overnight ER visit, and then followed by like a 3-day inpatient visit, followed by a 1-day gap. And this 1-day gap could be missing data, or it could be that the patient got discharged and then deteriorated quickly and they needed to get back. So we see then an ER encounter followed by being admitted right away. And then for some reason, the system develops 2 records for the same patient. So I developed an algorithm that took all of these records and cleaned them up and merged them when they were overlapping and contiguous up to a 1-day gap, and returned a single hospitalization without a start and an end date. Unfortunately, what we found is that about 7% of the inpatient records had missing end date, which meant that we could know when the hospitalization started, but we couldn't see when it finished. So we needed to do something else. And what we did is expand the algorithm into what we call the second stage, where we look for evidence of presence in the hospital. And we did that by combining data from vitals, medications administered that required the presence of the physician and the patient, diagnoses that took place on consecutive days, etc. So all of this combined showed us when the patient was present in the hospital, and we could figure out when was their last day. And we validated this algorithm by comparing it to the hospitalizations for which we had an end date. And we found high concordance. So that was great, but you can probably assess that this was very computationally expensive because there's like so many comparisons going on in there. All right, so the third challenge that I want to talk to you about, and definitely not the last one, but just giving you a taste, was the labs that take place at admission. So of course, we're interested in the blood work when the patient arrives to the hospital, things like white blood cell counts, lymphocytes, neutrophils, etc. But when we look at the data, for example, here, if you're looking for lymphocytes, there are like a dozen different ways of measuring lymphocytes. And then within each of them, there are like a dozen or more different units. Sometimes you can transform those units and standardize them. Sometimes these units are noise, they don't make sense, so you need to clean them. So we had to develop a heuristic to clean these lab measures, and in a way that was thorough, but also scalable, because we were not just interested in lymphocytes, we were interested in so many labs, like several dozen, from requests from the various research groups. So also challenging. So, okay, so now that this is the setting on how it's working with EHR data, we have these considerations that I mentioned. So how did we address the rapid delivery if we needed to do so much in terms of algorithms? So we converge into this workflow where we start with the raw data here in the corner that we received as relational databases with continuous releases. So that means that we were getting a delivery every few weeks with updated data. And very little lag of what was happening in the real world. So first, we queried this data with SQL queries, and it first went into the script that looked for the new PCR tests that were showing up so that we could update our list of acceptable diagnostic tests. And then that list, along with more raw data, fed into the case definition cohort creation script, the one that identifies who has COVID-19. Once we identify the cohort, then we fed it into the algorithm that extracted the hospitalizations, like I mentioned before. So all of these scripts were written in Python, and they were saved in GitHub for the version control, because throughout the year, we did end up updating a couple times and refining our hospitalization algorithm. So keeping track of the version was very important. Then the output of these scripts are tables. So for example, from the cohort definition script, we get a table that tells you these are all the patients that have COVID-19, and then a column with the diagnosis date, and then more columns that tell you how was this patient identified? Was it via a PCR test? Was it via a diagnosis code? And if so, which test and which code and what results? So that is very easy to analyze. Then from the hospitalization algorithm, the output is a table that just contains who had a hospitalization and the start and the end date, because that's all that you need. Those tables, we uploaded them to Amazon Redshift, and we save them in what we call the ARD space. And ARD stands for Analysis Ready Datasets. And they were also continuous releases, which means that we ran this part of the workflow every time we got new raw data, so that the analytic tables would always be updated. And then anyone within the organization could query these data sets via SQL queries, and they could write their analysis code in whichever language they prefer, like R or Python. And these codes were also saved in GitHub for the version control to serve the purposes of replicability and reproducibility that I will cover later. Okay, so the important part about this workflow is that we decouple the part of creating the cohort from the analysis, as well as the cleaning of the data. So this allowed several people, various members of my team, working on the different pieces simultaneously. So we were able to work efficiently and effectively and generate the first set of results for the EPI study quickly. All right, so now we got our results. And then the second consideration is making sure that they're reliable, right? So we want to know whether we can trust these numbers. And so how do you do that? We approached it via 5 different strategies. So the first strategy you're probably all familiar with is sensitivity analysis. So we ran extensive sensitivity analysis to answer the questions of, do the results look the same if I only define my cohort using PCR tests? Or do they change, or do they look the same if I only use official codes? If I focus on this one timing, etc. So you make all of these changes and run sensitivity analysis. Then the second strategy is the code QC. What that meant here was that we had, for example, an independent data scientist look at our codes and double code the parts that were the most critical, and in general, test the code, throw all the edge cases at it, making sure that it's doing what it's supposed to be doing, so that we can trust its output. Okay, so the third and fourth strategy are called benchmarking, which really means comparing to what has been already reported. So under normal circumstances, for like any other disease, you would have a large body of literature out there. But this being COVID, there was no large body of literature to compare to. So by the time we got our first set of results, we were lucky to find two very relevant publications. One was the Northwell study that came from patients hospitalized in New York City hospitals, and their cohort was large, over 5,000 patients. We also found this report, other publication from Kaiser, which is a network of hospitals in California. And this report was a cohort on their northern hospitals of over 1,000 patients. And they have reported some summary statistics that were very similar, were very relevant for us, and were super helpful to compare what we had. So for example, when we saw that 56% of the patients admitted in the hospital had hypertension, then we looked into these publications, and then we found that first, this number was within the realm of possibilities. And second, it was very close to what was reported in the Northwell study from New York City. And this made a lot of sense, because when we look at the geographical distribution of the hospitals that were, for which we had the EHR, they were heavily at that time representing the Northeast, which included New York City. So this was the benchmarking, and we did that for as many as we could that were reported. The fourth strategy for benchmarking was what we did was to license a second EHR data source. So this was completely different hospitals from all over the nation, and we had a different group of data scientists working on it, following our documentation to get the same results so that we can benchmark them. So the final strategy is called clinical consultation. We sat down with clinicians and people that have experience recording the EHR in the hospitals, and they were able to tell us how things work in practice. And via those conversations, we learned very important things. For example, supplemental oxygen, which is probably one of the most important things you want to know about COVID-19, is something that we learn is not properly recorded in the EHR. Like you couldn't trust that estimate. It's going to be underreported because sometimes it's not even recorded. And when it's recorded, sometimes it's just like a single bill at the end of the day. So you don't have those details that were of interest. So that's what informed us that we shouldn't report supplemental oxygen. And via similar conversations, we learned that the rates for acute respiratory distress syndrome, ARDS, and bacterial infections and ventilator-acquired infections, those were also underreported. But we could only have learned this via talking to the experts, not something that you could learn from the data. So this focus on reliability made us, happy to disseminate our results internally, but also happy to disseminate them externally via a preprint. And this preprint received a lot of media coverage. People were really interested in the rates that we had reported from BMI. Okay, so then the fourth consideration is replicability. Now, there are different ways to define replicability and reproducibility, so I made sure to write down what I mean by in this particular talk. And what I mean is being able to obtain the same results using the same code, using the same data. And this was very important to us because, like I mentioned before, we had multiple research groups that were interested in the results. So we need to be able to share our code so they could replicate it and obtain the same thing and build upon it. The second reason why this was very important for us is that we were working as a team, which meant that, I mean, we are all working on different projects, have different workload at a given time. So the responsibility of generating the analytic tables in the ARD space that I mentioned every few weeks is something that we rotated. So we needed to make sure that the whole scripts and the whole pipeline, it could be done by anyone, and it would always give you consistent results, the same results. Okay, and the last consideration, reproducibility, which in this talk I refer to or what I mean is reproducible results. So that is when you have an independent group of researchers doing your study, following your documentation and getting the same result. This was important for us internally because, like I mentioned, we had a secondary EHR data internally available, and we had a separate team analyzing that data. So that data had its own cleaning challenges, and the ones that applied to us didn't apply to them. But the design of the study was the same, and the details of how we were approaching it, the window of time, the settings, etc., all of that they follow, and they got the results that we use for benchmarking ours. So super important to have reproducible results there. Externally, and for the second study of the prognostic model that we did, we also wanted to share it externally, but we needed to have some data sharing considerations taken into account because we have a user agreement that doesn't let us share the data. But what we can share is all of our analysis on the clean data and a thorough and adequate scientific reporting on all the analytic parameters and decisions. So here I'm just bringing back the workflow again and like marking on red on the right-hand side, the part that we have made publicly available on a GitHub repository, this R code that covers our entire analysis for this model. And then the other red box is what we describe in the paper with scientific reporting. And what do I mean by scientific reporting? I mean, adequately report all of these analytical parameters, the data source, of course, but also the inclusion and exclusion criteria, the codes that we use, the care setting, the index date, the study period, any censoring data, the outcome definition and the predictors, as well as the design of the study and all of the software details. And we did that on our paper, which is currently available as a preprint, and it's also under peer review right now. And I'm not going to read all of that. These are just extracts from the text on how we were reporting each of these parameters. And what I want to emphasize is that when we're talking about the data source, we did describe where we get it from, but we also emphasize that any interested researcher can obtain the data in the same manner that we did. So we didn't have any special access privileges or anything. And that's important for a reproducible study. What I want to focus right now is on the code that is publicly available. If you're interested to know how we develop this rigorous prognostic model, feel free to check it out. What I want to emphasize is that it doesn't only include the code for the model, it includes all of the steps from the refinement of the code. For example, we only care about adults, to the preliminary data analysis, which is looking at the distribution of the variables, finding outliers. How did we decide which one to truncate? How did we decide when we find collinear variables, which one to keep? How did we perform the multiple imputation, and how did we evaluate that was adequate? To how did we perform variable selection and applied a group lasso to pick up those variables that had categories? To, of course, building the model and validating it, interpreting everything is in there. And the whole code, we put it as a supplement in the publication. So in conclusion, real world data for an emerging disease like COVID-19 definitely has unique challenges, very different from how it usually goes. We were in this initial situation where we needed a rapid delivery of these real world data insights and making sure that they were reliable, making sure that our studies were replicable and reproducible. We ended up using this workflow where the key part was to decouple the creation of the cohort from the cleaning of the data from the analysis, so that many people could be working on it at the same time. The code we verified was replicable, and it's saved internally, available in version control in GitHub. The results, we verified they were reproducible because we had access to the secondary data, and an independent group was able to rerun the study. And then externally, we had to also consider the fact that we cannot, based on our user agreement, share data, but we can share our analysis, and we could also share via scientific reporting all of the details to allow for independent reproduction. Yeah, so thank you for your attention.
Shemra, thank you so much. I I have no words. I'm looking at the repo. It's amazing. Does anyone else have any other? Does anyone have any questions or comments or appropriate hero worship for what Shemra did?
I wasn't alone. It was me and my team.
Rohan, it's Nick Radcliffe here. I mean, what you're doing, Shimmer, is very like the stuff we're doing, except that you can actually publish your code, which we can't, but hope to be able to do in the future. So it's really fascinating to see you taking similar approaches, and yeah, I think you've done a fantastic job as well, and really appreciate you sharing it. We'll definitely have a look at what you've done.
Thank you.
Maybe while people, oh, there we go. Chris says, did you have an issue integrating ICD-9 and ICD-10 simultaneously? You can tell I'm not a biostatistician because I sorry, not familiar with those codes.
That's a very good question. Definitely coming from somebody that has some experience analyzing EHR. Yeah, so just to give you some background, there are official codes for diseases, and there used to be the ICD-9, and then they created the new ones, ICD-10. But in practice, hospitals and medical coders, they still use what they were used to. So in real data, you have a mix of both. Yes, you have to be careful for that, and luckily in the data, you can usually tell which one they're using. So when you're writing your queries, you need to have, if it's an ICD-9, you do this, if it's an ICD-10, you do that. So yeah, we had to do that.
Jane asks about the data sources. Are the data mostly coming from the US, or did you also apply the model to other countries?
Yeah, the data was only for the US. Yeah, both EHR data that we licensed was from the US. Different hospitals, different regions, but only US.
Could I follow up on the data question? So in your paper, you say, you know, we don't have special access. Anybody can request this data. And then in the talk, you were talking about licensing the data. So if I wanted to do it, do I have to pay for the data? Does licensing mean I buy it from somebody?
Yeah, so to clarify is to access the data, you first have to license it. So that means you have to pay, and then you can bring it in-house. And there are all sorts of, well, I was not involved in the acquired, but I assume there are different types of licenses, etc. But because for us, it was like we all had access to it.
Are there, are you able to share like magnitudes of, like, are we talking, do you know if we're talking like millions of dollars or thousands of dollars?
Oh.
Or I mean, share whatever you.
I thought you meant about data points. It's like billions of data points, but in terms of money, I'm not able to share because I don't know. I'm not the person doing that.
No, of course. Does anyone else have any other questions?
Actually, I have one more question, if it's okay, Rohan. Obviously, you can't share the data. Completely understand that. Did you create any synthetic data or any test data or anything that you can share so people can at least see if they can get the same results as you on test data or anything like that?
Yes, that is a very, very good question. And it doesn't apply to this study, like that was not something we considered or we set out to do. But for other data that I had experience with that is similar, it's not the same source, but it's similarly in that it comes from a third party and it's licensed, and we had to run a model, and it was very important for the reviewers to be able to check it themselves. We did create synthetic data for them. We ended up putting the synthetic data in their Git repo that is connected to the publication with a tutorial, so that people really could get a sense of what our model was doing in this, but it's not for COVID-19, it's in this other paper. And if you contact me, I'm happy to share it with you and talk to you about that one.
Yeah, I think it's a great approach. We're looking a lot at synthetic data and I think it's a super powerful way of extending it so that even when you can't share the data, but you can share code, you can share stuff that lets people, you know, replicate more of what you're doing and build confidence. So it's an interesting area.
Definitely.
If anyone has any other questions, then please just chime in. But how did the team? I mean, obviously, I'm assuming the team was all distributed because you were working from home. How did the team come together and actually work on this together? Do you have any tips for distributed teams?
We just met all the time. We basically online the entire time. There was definitely lots of communication. We did have one, we call it the A team. So everybody was together was the A team for COVID-19. And we did have one meeting a week where everybody was in attendance because we were not only doing these studies, but we also had a dashboard that tracked everything internally so that everybody could see what was going on in the data. So yeah, we had one meeting where we met weekly just to go over everything so that everybody would be on the same page. But besides that, it was more like sub-team kind of meetings. And I was able to be part of all of them. So I knew like what was going on in all the pieces. And that's how we did it. And lots of Slack, lots and lots of Slack.
So Slack, and do you use a like GitHub, GitLab, or?
We have a GitHub that is internal. Yeah, and we use basically the meetings and the Slack to do all of the within team communication.
And then do you do much pair programming, or is it mostly folks, you say, okay, well, you go and make some charts, you clean up the data, and then we review it afterwards? Or is it, I mean, you mentioned that you had that person come in afterwards as well, but is there any pair programming that you do?
We don't do pair programming and we have different levels of QCing. So we have from the top one that is double coding just to check everything, to other several intermediate levels of reviewing of your code. It really depends on how critical it is.
Yeah, absolutely. Yeah. Does anyone else have any other questions that they wanted to talk about? So I mean, I'll follow up with them on medRxiv, just because I know the repo. One of the talks later on is actually about medRxiv. So, to what extent were there a lot of other people sort of doing similar similar work? Was there pressure that you felt, I've got to get this out, I've got to get this?
We didn't let anything external pressure us. It was our first goal was to do useful work for our teams that had asked us specific questions, and they were interested in very specific things, so that we were first doing our work for them. And it was more after we had it like, hey, this is useful, so maybe it's going to be useful for other people, so let's put it in a medRxiv. And it was, and that's why it got picked up by the media. Yeah, because it was reporting results for a very, very large cohort. So actually at the time, it was the largest cohort in the US, over 16,000 patients.
Okay. And then how do you, the tempo would have been so high when you were doing this, like it would have just been really intense. And how do you then come off that high tempo pace and then keep going on to other projects? Do you have any tips for that?
I don't have any tips, but I know exactly what you mean. It was like we were going 1,000 miles per hour. Yeah. I think that was a very personal experience, and it was different for different people because we all had like our own portfolio of work, and we were only all converging in this one. For me personally, I finished this one, and then had this other one, the one with the data set that was that I just mentioned, synthetic, and that one was also picking up speed. So it was just like jumping from one train to the other. It was much later in the year that I was able to then like take a step back and do other things. But I don't have any like wisdom regarding that.
Does anyone else have any other questions?
Am I the last thing on the way for a break?
Yeah, exactly. So we can talk for as long as we want. No other questions. Oh, I might just say thank you once again for just a wonderful presentation. Thank you so much, Shemra. It's just remarkable what you did and what you achieved.
Thank you so much for the invitation.
Oh, what's your child's name?
Do you want to say your name?
You say hello.
His name is Joshua. He is
Hi.
6 and he did a very good job in the background.
Hello. Thank you so much. Really appreciate it, Shemra. Folks, we're going to take a bit of a break. I'll keep the stream going and things like that, so we don't have to worry about resetting that. But we'll probably stop through till the talks start again at 2:30. So for those of you who aren't in the Toronto time zone, that's roughly an hour. I'll be away for about half an hour, and then I'll be around after that. So if anyone wants to chat, that would be great. Otherwise, see you back in a little under an hour.